know.
Trying to get started.
Good morning.
Oh, yeah.
So now I told Sarah I need a.
I could come up here with my glass and start tinkling on it, but then you think of something else.
So I started with my wife.
Glad to see you again, glad we can be together. We're gonna do the order of things just a little bit different this week. In that we're gonna have Bob come up and talk first, and you'll find his notes on the last page of your handout there. And then we're gonna get into some of the issues that relate to medical stuff relative to finishing well. Some of the things that are good to know or be helpful to understand about our bodies and so forth. I don't know yet why they chose me to talk about that, but we'll. But let's start with a word of prayer, okay? Father in heaven, we're so glad to be able to come together on this Lord's Day here in the church that we call home, the church which is part of the body of the bride of Christ. And we're so very thankful to be able to be here and fellowship together and relate well and learn and worship and come to know you better. And so we look forward to what we're going to be doing today and talking about in this session. Thank you, Heavenly Father, in Jesus' name. Amen.
Bob, before you start, real quick, just an aside, we are video recording these sessions. We did a test pattern of it last week and it worked out pretty well. Angie Johnson has actually made that a post on a YouTube post and a Facebook link that I can give you if you want to be able to do that, or we could make a recording of it from there. But we're recording from the back, so just if you have interactions that are happening, make sure you just speak up enough so that we can hear it from the back. And then, like I said, we'll be able to have that available for people. So if you missed a week, you can catch up. So.
This week we're going to take a look at King Solomon. King Solomon is the son of King David. And for last week, one of the things we talked about at the very end of David's life, God is saying to him that if your sons who will follow in God's ways, you'll always have a king in Israel. If we look at King Solomon, he's a classic example of starting well and finishing badly. And we've seen his life in any generation, including ours. What we allow in one generation, the next generation is going to take it about 3 steps farther. So we'll just take just a brief look at him. We see that at the very beginning of King Solomon's rule, that God said to him that he will give him wisdom and knowledge that I may lead this people in a way where he's able to govern such a great people. This is what he's asking, and what God says to him is that he'll give him wisdom. You look it up in the first chapter of 2nd Chronicles. This is where you'll find all that. We find that Solomon is not only given wisdom, but if we read this, it says, and I will also give you wealth, riches, honor, such as no king who was before you or ever had, and none after you will have. Now, that's a statement I think we should just take a good look at, because if you realize what Solomon was doing and what he had, it is just staggering. If you move up to the 2nd Chronicles chapter 9, 13 through 30, it lists his wealth. Now, if you think of Saudi Arabia and the other countries in the Middle East and these kings, and you say, boy, they have got bucks. They have nothing to compare with Solomon. Solomon had rooms filled with gold, literally. He had, and it tells in there about his utensils, what they ate with, forks and knives made of gold. He had steps inlaid with gold. He had shields made of gold, and it just goes on and on and on. And in fact, it said that they didn't consider silver to be of much value. In fact, it was just kind of common thing, that really didn't have much meaning to them. That's how abundant gold and silver were in his kingdom. So just think about that one for a minute, because today, silver's got pretty good value to it also. But at that time, it was that abundant. We also look at Solomon and say he was an incredibly intelligent. This man did many, many things, including huge building projects. He was into the arts and just did anything he desired, he did it. He was king, he had no one to be accountable to, and he had no limit on his wealth. So he could pursue whatever he wanted, and he did. And one of the things you find is that as life goes on, things start to slowly change. One of the things that David had multiple wives. When we see the next generation, which is Solomon, this is carried to an extreme. The commentaries list that he had approximately 1,000 between wives and concubines. It numbered 1,000. And that's a pretty big number. And with it comes all kinds of trouble. And one of them is that these wives, over time, turned his attention from God, the living God, to all their other deities that they worship. And this is what really changed things for Solomon. And Solomon, you just kind of see a steady progression down from that point on. One of the really interesting reads that you'll have will be Ecclesiastes. This is Solomon near the end of his life, and he's an old man now, and he's just looking back at his life, and it's a really good read. If you haven't read it recently, take the time to do it. It is fascinating, and you'll find just a lot of information in it. Now, I'm going to just get a couple things from that. This is from chapter 2, verse 11, and it says, yet when I surveyed all that my hands had done, and he did a lot, and what I had toiled to achieve, everything was meaningless, a chasing after the wind, nothing was gained under the sun. That's quite a statement for a guy, and especially with the vastness of his wealth, the vastness of the things he did. And he was known literally throughout the entire world that existed at that time. The other one that is very interesting, if you go to the 13th chapter of Ecclesiastes, the very end of it, the last two verses sum up what Solomon really wanted to convey to us, and it's really the most important. Now, all that had been heard, here is the conclusion of the matter. Fear God and keep his commands, for this is the whole duty of man. For God will bring every deed into judgment, including every hidden thing, whether it is good or evil. Last two verses. And so I'd encourage you this week, read Ecclesiastes. It's a great read, especially if you do it in some of the new modern versions that are very easy to understand. The one other thing that I'm going to highlight here today, you'll see a number of books up here. This will give you an idea of some of these sources of things that I'm using. This book is in our library next door. There's two versions of it. It's called Heaven by Randy Alcorn. This is the 100-page one. The one in the library is 450 pages. I've been through that one, and now I'm going through this one. It's just a condensed version. We had a girl, a friend of Shirley that gave us this book, Jesus Calling. There's Jesus Calling and Jesus Today. They're by the same author, but they're different. The one that I've liked the very best has been the Jesus Calling, which I list up there. And I'm still reading it. Every year I'm going through it. It's an amazing book. This is the one that we listed up here from Swindoll. This is about $10. Well worth getting. This is all these people and their end of life, what they had to say at the very end of their lives. This came as a Bible study. There's 4 books in this series, and that's the one you see here listed, Life Principles. And it is really worth your time to consider this. This is just a phenomenal Bible study. One that I'm going to leave for Tom Cairns talked to me about, and we're just going to start reading it, and it is called Why the Church Needs Bioethics. And very, very interesting. So I'm going to leave this up here because he'll reference that this morning. And that's where we'll stop for today.
Thanks, Bob. So, I want to take it from where he left off, and I really would like to have you turn your Bibles to Ecclesiastes chapter 12. He referenced chapter 13, but it's actually chapter 12. And, you know, this guy was one of the wisest men ever to live, if not the wisest. So, what did he have to say about finishing well, or what did he have to say about aging? Ecclesiastes chapter 12, verses 1 through 7. And I want you to think with me, what is he saying here? I'm going to read this first of all from the Message. Now the Message is a version which is written by Gene Peterson. He changed a lot of the wording to be very contemporary. So let me just kind of read it and see what you think of it. You can follow along in your Bible. Honor and enjoy your Creator while you're still young, before the years take their toll and your vigor wanes, before your vision dims, and the world blurs, and the winter years keep you close to the fire. My wife is laughing about this because I'm always wanting the warmth in there. In old age, your body no longer serves you so well. Muscles slacken, grip weakens, joints stiffen. Anybody feel any of this? The shades are pulled down on the world. You can't come and go at will. Things grind to a halt. The hum of the household fades away. That's why I'm wearing a hearing aid. You're awakened now by bird song. The littlest thing, the littlest sound. Oh, wait, what was that? Hikes to the mountains are a thing of the past. Even a stroll down the road has its terrors. Your hair turns apple blossom white, adorning a fragile and impotent matchstick body. He refers to it there as a grasshopper. Yes, you're well on your way to eternal rest, while your friends make plans for your funeral. I mean, he's putting it in very graphic terms here. Life, lovely while it lasts, is soon over. Life as we know it, precious and beautiful, ends. The body's put back in the same ground it came from. The spirit returns to God, who first breathed it. You know, he was going through the process. He knew what he was talking about. He was pretty old at that point. He was feeling a lot of the same stuff that a lot of us are feeling as well as these things come along. And then he says, it's all smoke. Nothing but smoke. You know, that he says vanity. We say vanity of vanities from the King James. The quester says everything is smoke. And then he goes on to those verses that Bob read a few minutes ago. Fascinating. You know, and where are we? You know, the loss of hearing, the loss of vision, loss of ability to move our arms and legs, no longer able to climb the mountains or do those things that we used to be able to do. You know, he knew what he was talking about. So I'd like to have us look at the outline I've given. There's no conceivable way I can get through everything, but I wanted to put it down in writing so you could reflect on it all yourself. Now here's the deal. I want us to have discussion. I don't want this to be a lecture. On the other hand, when we're dealing with medical stuff, sometimes there are privacy issues involved, so we want to be a little cautious there. And sometimes there are just plain personal issues, and we aren't here to do a medical consult. So I just want us to be careful in our discussion to, raise issues of general interest and not something that's, specific to my particular ache and pain kind of thing. So let's just keep that in mind and talk. First, I really want to point out that there is a real difference between aging and disease. And sometimes they get very confused in our minds. I'm at the point where this is bothering and that's bothering, and the question really is it because of illness or disease, or is it just a normal process of aging? So let's look at some of those things where aging plays in. Our heart tends to get a little slower, it gets a little stiffer. It doesn't pump as effectively as it used to be. We get into hypertension. A lot of people deal with hypertension and heart failure. Those come along largely because of aging. Whether there's disease involved or not, those are just common changes that occur in aging. And the blood vessels get more fragile, and they rupture more easily. How many of us have little black and blue marks here and there because we bump into things and so forth? The brain, memory gets a little less efficient, doesn't it? Yeah, here's some amens here or something. A little harder to learn anymore. And the bones, they tend to shrink or lose density, and we tend to get a little shorter. Is that disease? Not necessarily. That's just a very common part of it. And more risk of fractures. And the joints, we just naturally lose cartilage. Now we can accelerate that by abusing the knees or the hips or whatever, but we tend to lose cartilage, and then we get the bone-on-bone thing. More with arthritis, and the skin getting thinner, tearing more easily. The risk of accumulated sun damage. I suppose you could say, well, that's kind of disease because it's external, but it's real. Less elastic, a few more wrinkles showing up. Digestive system tends to get slower with more risk of constipation. And then, of course, all these things are affected by outside circumstances. Like then if we're taking certain medications, we get more constipated, or things like that. The urinary system, poor bladder control, or less bladder control, moving toward incontinence and so forth. And our vision, close-up vision gets to be an issue. We tend to hold the book a little further out when we're about 40 years old, and when we're 45, we're moving toward trifocals and that kind of thing, difficulty focusing. And then the lenses cloud up. Now, lens clouding, we call it cataract, can be part of the normal aging process, but it can also be because of ultraviolet light we're getting, and many other disease things, diabetes, and those things all play into it too. But it's a part of the normal aging process. And hearing. Yes, hearing is greatly affected by noise that we've heard when we were kids and high volume, but it's also just part of the aging process to lose hearing as we get older as well, especially in the highest ranges, the sopranos and the violins and that kind of thing. And weight getting harder to maintain. Not necessarily one way or another, but harder to maintain it at whatever equilibrium we're at. But we do need less caloric input as we get older. And sometimes we don't realize that, and we keep eating like we did when we were 20, and then we start packing it on. Sexuality, of course, impotence, erectile dysfunction, vaginal dryness in women. So these are some of the typical aging things that come. What do you think of that? Any comment? Anybody agreeing with this or disagreeing? Right.
Just a question about some things I've seen the last, 10 years about mental intelligence stimulation with luminosity and these other things, about the benefit of continuing to learn new things outside of your scope of to keep your mind young. Do you have any
Absolutely.
feelings about that kind of thing?
Keeping your mind young by using it. But the same is true of our knees, keeping our knees and the rest of our body vigorous by keeping on using it. One of the greatest problems with aging is becoming sedentary. And as we become sedentary, all these things go bad. The mental function goes down, the physical function goes down. So the sedentary lifestyle is a huge, huge problem.
You can accelerate the digression by sedentary life, and you can prolong the capacity by increased activity.
Absolutely.
Especially in our society.
Pardon me?
Especially in our society, everything's so easy.
Yeah, we don't have to work hard to make a meal, we can just pop something in the
Yeah,
microwave.
you can drive everywhere, you can turn on the TV and just be mindless.
Yeah. You know, having worked in Congo for so many years, everybody would walk wherever they're going. I mean, it could be 5 miles, it could be 20 miles, and they'd carry a load on their heads, or whatever, you know, and they kept physically fit. And we don't do that as we get older. That's a big issue.
Comment a little bit more about benefits for exercise programs and just generally really working the body.
Yeah, well, you should be the one to say that. You're the expert, man. Yeah, no question. Even if it's just very limited exercise, but consistent is what counts. Consistent exercise. 3, 4, 5 times a week, very consistently doing stuff. And this, I think, is one of the big reasons why Bob is as healthy as it is today, despite the malignancy and everything, because he was so compulsive about exercise for so many years. And we need to keep doing it. We really do. Well, compare that then to the next page. And this is just a broad term. By the way, Peggy, you are very much of an expert on a lot of this stuff. Don't hesitate to jump in. I don't know if you know, but Peggy is a geriatric nurse practitioner and very knowledgeable on stuff like this. So, geriatric syndromes, these are combinations of symptoms, or syndrome is a word that basically says there's more than one specific symptom. There's a number of things that come together. Sometimes they all have to be there in order to make a particular situation. Sometimes one leads to the next, but we call them syndromes. It's a broader word than just a single symptom. Difficulty swallowing. As we get older, this can be an issue. It might be a problem because we just can't get those pills down, or can't handle a big piece of steak anymore like we used to, or choking on fluids. You know, we take a drink that maybe in the past it was no big deal, and now we're coughing on it, you know, because the mechanism of swallowing here doesn't do quite as well. But the problem then is those can lead to other things, like aspirating into the lungs, and then we get a little pneumonia. Or getting into other infections in the throat and so forth. Or it could be that the swallowing thing indicates there's something going on in the brain that has caused that loss of swallowing function, like a tiny mini stroke in that particular swallowing place. So that would be a syndrome that we see in the older folk where swallowing is an issue. Malnutrition. You know, a lot of people don't eat well. Again, Todd, you're saying, yeah, in our culture it's so easy, but the reality is a lot of people don't eat well, and especially if it's a swallowing issue. Then they don't eat good quality stuff, or they're eating very soft stuff or special stuff that won't, you know, that will not be a problem for them. And malnutrition can be in two different ways. Some people would say malnutrition, they mean they're getting all skinny and wasted away, and others, malnutrition is where they're grossly overweight. That's malnutrition. Badly nourished in the wrong way. And all the things that come along with that, because then you get into diabetes or get into some of the other metabolic things that we'll talk about in a minute. Bladder control issues, we alluded to that earlier. Wow, those are significant issues. How big a business is it for adult diapers? Depends. Name the product. I mean, it's a huge, huge business in this country. And many of us aren't aware of it because they're kind of hidden, and But reality, that's a big deal, as we have a loss of control. Sleep disturbances. Now, as we get older, it's a normal thing to have some sleep disturbances, but sometimes they can be pretty significant. Maybe it's because we're having sleep apnea, where we're not able to breathe without choking, or getting into issues of stopping breathing throughout the night. Sometimes multiple hundreds and hundreds of times during the night even, and so we wind up using a CPAP machine as a way to avoid that. But then there are just very, very light sleep. We can't get to sleep. How many people come into the clinic, just an urgent care where I work, and mostly we're dealing with sprained ankles and lacerations and stuff, and then you get somebody who comes in and says, I can't sleep, I need a sleeping pill. Well, wait now, that's something your primary care doc should be dealing with you on, but that's a common problem, is sleep issues of all sorts. Delirium. I want to talk about that one a little bit, because a lot of people get it confused with dementia, the next one. Let's look at dementia first. Dementia is just a group of symptoms caused by disorders that affect the brain. And it is not a specific disease. Now, we all think, dementia, well, that's Alzheimer's, isn't it? Yeah, that's one of the, maybe a dozen or two different kinds of dementias. It's the most well-known, it's the one we hear about the most. Vascular dementia is another one. That's where you've had hypertension too long, or your blood vessels in the brain are getting too narrowed or too clogged, and then you start having little tiny mini strokes throughout the brain. Not the big massive stroke like where you're paralyzed on one side, but the mini strokes. And that becomes vascular dementia very much. And to the average person, you might not realize this guy doesn't have Alzheimer's, he's got vascular dementia. It's a whole different thing, caused by a different thing, but it looks a lot the same. And the examples, you get to the point where you just can't think quite as clearly. You're unable to do basic activities of daily living. Now we define two categories of daily living stuff. There's activities of daily living, which would be like, eating, dressing, toileting, and so forth. And then there's instrumental activities of daily living, which are the ability to do things that you used to do around the house. Cleaning the house, washing the dishes, locking the door, basic things that you need to be able to do to function. But when it gets to the point where your activities of daily living, like eating, dressing, toileting, are going on, that could be part of the issue with dementia. Difficulty controlling emotions. People can get agitated or see things that aren't there. And that's an issue. And then memory loss. That's one that we think about the most often with dementia. Yeah, that's really real, and it's common in almost all forms of dementia. And difficulty expressing oneself, the ability to elaborate thoughts, to come up with the words, you start getting circuitous in your description of things and so forth. So that would be dementia, a long chronic thing. Now I want to contrast that with delirium, which is much more of an acute condition. It's usually circumstantial. Suddenly something's happened, you're in surgery, in the hospital for surgery, hip surgery or knee or whatever, and all of a sudden you're not thinking straight and you're seeing weird things. You've got major confusion going on. This can happen because of physical illness, mental stress, things like that, and it's usually temporary. It may be a few days, it may be a few weeks, rarely a month or so. You're kind of seeing spiders on the wall, or you're seeing weird things that aren't there, or you just can't connect with people, or you can connect briefly, you know the name, but then you're wandering off in la-la land again. That would be delirium, but that is not dementia. So that's a different geriatric syndrome. And vision issues we've talked a bit about. There's so many things that can decrease our vision. We've talked about cataracts. There's macular degeneration that some people here deal with. There are issues of of glaucoma and so forth. And the issue here is, ultimately, we're concerned about function. And if the function of the eye is vision, and suddenly those diseases are coming in, our vision is decreasing, and then we have other problems related. We're not seeing things as well. We're not able to drive as well. We're not able to read as well, or do things that we were used to doing. And then compound that with hearing. Now, I'm finding myself in both of those categories. I've got the hearing aids, and I've had the cataracts, and I've got another little thing going on in the eye, and you start realizing, wow, I'm tending to withdraw from the world. I don't see as well, I don't hear as well. I get out there in the foyer and of the church, and there's all this loud conversation, and my wife is standing there talking to somebody, and I can sit there, I don't know what you're saying, I have an idea. but that's what's happening. We tend to get into a withdrawal thing when those sensory things start disappearing. Things like dizziness, lightheadedness, spinning. People have different words for it, and there are actually different combinations of symptoms, but dizziness, and sometimes that can lead to fainting or to falls and difficulty walking. All of those kind of come together, don't they? Somebody's a little dizzy, more risk of falling, or they're more risk of fainting perhaps. And of course, falling then can often lead to fractures, and that's because of osteoporosis. All these things kind of come together and play in. And that's because our body is a unit. It's many things, all these symptoms coming together, like he talks about in 1 Corinthians, the body is a unit, and we've got all these different functions, different parts. Well, that's true. We've really got that. What are your comments on these syndrome things? Oh, there's one other I wanted to add there too, by the way, it's not in your notes. There's something we call metabolic syndrome that I forgot to put in. Metabolic syndrome is a very important one. It's only been diagnosed in the last, say, 15 years or so, 15 to 20 years. And metabolic syndrome is where we tend to have high blood pressure, high blood sugar and or diabetes, high triglycerides in our cholesterol triglycerides, and high LDL, those two going together often, and truncal obesity, where we have a lot of extra reserves in the belly. That combination has a high probability of leading to diabetes, to stroke, to heart, to all kinds of things. And that's metabolic syndrome. So all these things come together. Now, what are your comments as you look at that? Do you see some of this happening? It gets uncomfortable, doesn't it? We really do see that, don't we?
Creeps up on you.
Yeah.
So you think you're all well, and all of a sudden one day something isn't working like it was, and you think everything was great, and
That's
go to
right.
the doctor and find out
Yeah.
you get the shock.
One thing leads to another, and oh my, yeah.
I find that the aging comes sooner than I would expect.
Mm-hmm.
I don't expect to be old until I'm over 80 or 90.
Yeah. Those
Five,
aging symptoms
finding
kick in
symptoms.
way earlier than we anticipated. Yeah, that's right.
Or we can see our parents in
Oh,
all
yeah.
of this,
Oh,
and
yeah.
then we think, oh, but they were older, oh, but no, it's not, it's hitting us now.
And maybe we're just 20 years behind every step they took. They're 25, yeah, that's right.
You know, and
Thank you.
Tom, I wanted to thank you for mentioning with malnutrition, that could be both underweight or overweight.
Yeah.
And I would add to that, especially as we're thinking about helping our aging parents or that kind of a thing for those of us in that generation, the overweight, it's easy for people to think, you know, they get thicker, they get heavier.
Yeah.
And well, I'm just gonna eat light, and so they eat the fruits and the vegetables and thinking that they're eating light, but they're not getting enough protein. So clinically, in my job area, sometimes we end up seeing someone who's overweight, but yet their protein levels are very, very low.
Yeah.
And that can have bad effects on their overall health and recovery and getting stronger and things like that. So as you're kind of watching out for your loved ones or your neighbors or those kinds of things, one of the things to keep in mind is, yeah, they're eating light, but are they eating protein?
Yeah. Good point, thanks.
Another thing that I've discovered from different people is, that goes along with nutrition, is when, if someone's wearing dentures and they lose weight, their dentures don't fit properly, so then they don't eat properly.
You know, you tend to think, well, my word, the gums are, I mean, they're just kinda bony under there, why wouldn't the dentures keep fitting? But they don't. The dentures that you had, that you've been using for 5 years or whatever, you start losing weight and they don't fit, they're flopping, you can't keep them glued in and that kind of thing. Or there are people who have had a bunch of teeth pulled but have chosen not to get dentures, and so then you're trying to chew stuff and you can't get those teeth, the same teeth to work together very well because you don't have as many, and all that plays into it as well. Yeah.
That was another thing I was gonna bring up was, I've noticed people that are older often will chew only, they'll bite with their front teeth and they will chew with their front teeth because they have no molars left or the bridge broke.
Yeah.
And so I think it's very important for us to keep our teeth brushed and flossed daily,
So true.
because the tooth you don't brush or floss is the tooth you're gonna lose.
So true.
And it's going to be very important 20 years down the line for you and I if we lose that tooth, because if you want to perhaps get a bridge because one went out, they don't have anything to attach it to. So you can't get one, so there you have nothing to chew. One other thing I wanted to ask you about was pain.
Yeah.
You didn't mention that on here, but I kind of think that as we get older, we don't notice pain as much. We don't notice the cold, and so we go out without a jacket, or we go out with the jacket unbuttoned, or open, or no gloves.
Right.
It becomes a huge issue.
Yeah. For some, that's really true. That really is. Bob.
Another one I'd add, both of my parents wore their bodies out, literally. Back to doctors, that's what they said, is you just wore yourself out.
Yeah.
And there's a balance between doing work and just working to the point where you just wear everything out.
Yeah.
And they chose the second one.
Yeah. You certainly want to keep active, but that would be the extreme then, the other end. Yeah.
I wonder what test we should ask for, because I don't think I've ever had my protein tested. I don't know, what, when you have your blood tested.
That's not a blood test that would be typically done for that purpose.
Yeah.
I mean, we can test serum protein certainly, but it doesn't have a close alignment with what you have eaten the last few days or anything like that.
But even what, your vitamin D level or all that, it seems like you almost have to ask for it, it's not automatic, and
And there are reasons for some of that. There are reasons trying to keep costs down, medical costs being as high as they are, you try not to test excessively or inappropriately. So yeah, it's something you talk over with your care provider, your doctor, your nurse practitioner, whatever, and if it seems appropriate, it can be done. It certainly can be ordered.
In some tests, insurance will not pay for. So
That's correct also.
that's
Though
reason why
that
they
sort of
don't.
thing probably would be paid if there's a clear justification in the medical note for why you're ordering it. Yeah. I wanna move on.
What would be some symptoms of low protein? Just hunger, or is it just that?
The kinds of things that, now, my job, I work in nursing homes, and quite a bit of my work is with sick people who are coming from the hospital, coming to the nursing home for rehabilitation, and then hopefully we'll be going back home. So the types of instances where I might look at that would be if a person has a lot of swelling in their legs, if they have congestive heart failure that isn't really responding well to treatment, because you need enough protein in your system in order for the water pills to work sometimes. Another thing that I look at is if someone is very weak, if they've been in the hospital for a long time, they probably haven't been eating well. It's going to be hard for them to build up muscle if they don't have protein in their system. Those types of things.
And just one thing just, which is environment. Because if where you spent your life has a lot to do with, I think, agitating these or putting them into place sooner than you
Yep.
probably
Yep.
would normally.
Absolutely it is, yep. Okay, well, I'll keep moving here. One of the most significant syndromes, and I put it down to a separate paragraph here, is depression in the elderly. Depression is a huge one, especially post-retirement. Suddenly, the guy or the girl is not working anymore, and our identity often is related to our job. How often do you meet somebody, and the second question is, where do you live? And the third question is, what do you do? You know, I mean, that's so common. And our identity seems to be tied to our job, and suddenly we don't have that identity anymore. No, I sit at home, or I play golf, or no. You know, what is our identity? So depression easily kicks in, and it's often unrecognized because while they may be depressed, they've also got lots of other symptoms. The symptoms can mask the depression, but the symptoms lead to the depression. So it's a combination thing. And it's especially an issue in men. Now, it does happen in women too, very clearly it does. But the highest rate of depression leading to suicide is in older men. There's some statistics here, and there's a resource at the bottom of the bottom there if you want to look it up on the web to learn more. This is a big deal. I mean, we often think about, well, the teenagers get, you know, depressed and commit suicide. Yeah, right. But the highest risk, the category age group, is the elderly and especially men. And the most common modality is firearms. Now, yeah, you hear about slicing wrists and things like that, but the most common is firearms. So the question is, are we aware of it? Are we thinking of this? Are we conscious as we're helping other people, older family members, friends that we're visiting? Are we aware of the fact they could be seriously depressed? And these questions need to be asked, and it's something that you'll probably notice in your clinic. Very often, when you're signing into the clinic, they'll ask questions about abuse in the home, or you have firearms in the home, or they'll ask about depression, and that's wise, but we need to be conscious of it too. That's a real issue. Now, all of that in mind, I want to make just a couple brief comments. Pat's going to talk more about this stuff next week, but I just want to point out, getting medical care, once you hit that 65 age, you really want to get signed up for Medicare pronto. That's a wise thing, and the Part A is for hospitalization stuff. That's pretty much automatic, that's what you're going to do, and B is for doctors. And there's a little bit of a premium deduction that you lose from your Social Security to pay for that one. In other words, that's not totally free, it's mostly free, but you pay a little bit from your Social Security check. Part D is the drug benefit. And Part D is an important one because sometimes we are winding up taking a lot of medications, and D will cover almost all of it, but you've got to sign up at the front end on that. If you wait until a year or 2 or 3 down the road and say, boy, I should have signed up for D, you're going to get a penalty, a significant penalty, don't you?
Yeah, my mom, she didn't do that. She didn't have it, and then at the end of her life, she had to take these medications that were like $350 a month.
Yeah.
And she had to pay for them.
Yeah.
And when she finally did switch, she was gonna have a huge penalty, but by then it was too late.
Yeah.
So
Yeah,
she
yeah.
went through a lot of money for
Right, exactly. Jerry?
Well, the other side of that, Part D, is the fact if you are working and you have insurance covered through your work,
Yeah.
then you don't have to sign up for Part D,
Correct.
like I am right now.
Right. If you're continuing on, yes, that's
If
definitely
you've
an
got,
exception.
if you've got insurance coverage through work, et cetera, like that,
Mhm.
spouse, work, whatever.
Right.
Then,
Right.
but as soon as that is gone, then you start
Right.
go after Part D.
Yeah. Now, the supplemental policies. Every one of our major carriers all offer supplemental policies, Blue Cross and, you know, every one of them, health partners, all of them. The supplemental policies have really made a huge difference for Annette and I. Just having that supplement, what Medicare doesn't cover, they pretty much cover, we have very little to pay. Now, yeah, you've gotta, you know, there's a policy premium you have to pay, but wow, in the long run, it really gets worth it. And then there are important decisions you need to be making, and this is what we'll be talking mostly about in week 5. We're gonna give you a whole long list of big decision things that you need to be thinking about. Ranging from your care network, your provider, all the way down to cemetery decisions and wills and all kinds of stuff that we're gonna kinda, you know, share with you, things to be thinking about. One of the things you want to think about here is what level of care you should be at, and when should you move from one level of care to the next. If you look at the next little sequence on the next page there are 5 basic levels of care to be aware of. Independent living, that's what most of us are now. Independent living totally. In our home, or perhaps in a senior living complex, but we're living independently nonetheless. And then sometimes we start needing some help. We need extra care, maybe with some toileting issues or dressing issues, or maybe it's just having somebody help get us a meal, a good square meal once a day, or getting some medications set up for us so that we don't have to get them all mixed up and forget them and so forth. That would be assisted living. Then if we need a lot of care, if we're really sick, we have to move on then to skilled nursing care. Now, there's 2 specific unique ones. One of them is called memory care, and that would be, of course, for people with the various forms of dementia. And there, it may not look a lot different from assisted care. In fact, very often, memory care can be done in an assisted level environment, but they're doing things that will help with memory things, helping to conserve memory and helping to serve you with those memory issues. And then there's the point where you might need to be in a locked unit if you're a wanderer. You hear stories every winter about somebody who's wandered away from a facility or a home and wound up in the dead of winter out in the snowbank, or things like that. So there have to be special situations like that. Then there's hospice. Hospice tends to be where we're getting near the end of life. One of the really sad things about hospice is it's a wonderful program. It's really used much too late by most people. Much, much too late by most people. You can start using it within like when you're 6 months out before end of life. If you or your doctor are saying, you know what, I don't think I'm going to be around 6 more months. That's time to get hospice involved early. That's virtually free care. Now, you're not going to be having new diagnoses made. You're not going to be having aggressive therapy or anything like that. That's not going to happen. This is for keeping you comfortable, helping things sustain life, keeping you in a pain-free setting with enough oxygen or whatever you're needing. But it's really a good idea. It's a sad thing when people don't go into hospice until 2 days before they die. I mean, that's a total waste, and they could have been getting much more care long before then. I saw a hand here, Bob.
Would you just take a minute and talk about palliative care versus hospice?
Yeah, palliative care is evolving. Palliative basically is a situation where you're caring for the person and keeping symptoms well under control, but you're not aggressively going after that cancer or chemotherapy type stuff. And you're helping in that way. There are a lot of implications, broader implications that we can go to. But yeah, that's a big thing. And by the way, if you're interested, and let me just throw that one out again. This book that he referred to, Church and Bioethics. Now, at first glance, you might think, wow, that's something the pastor and the elders should read. And actually, yeah, we're recommending the pastor and elders read it. But it's 3 case studies. The first one is all the issues that pertain to the beginning of life. a case study and then 3 or 4 chapters, one by a theologian, one by a pastor, one by a physician, so forth, about, you know, in vitro fertilization or surrogacy parenting or things like that. And then the second one is middle of life questions. And then the third one is a case study about a guy who's dying of pancreatic cancer. And then again, you've got a lot of medical stuff and a lot of, it's very readable. And if you're interested in knowing what are the implications of, say, having more morphine so I don't suffer, is it going to be a good thing or a bad thing? Is that going to hasten my death? What are the implications of tube feeding? What are the implications of having you know, oxygen versus not? And what are the, you know, all kinds of bioethical issues, and that third section there is worth the price of the book, very honestly. It's really good. It's like a $16, $17 book or something.
The next step, it was
Okay.
or $21.
Yeah, but it's a really, really worthwhile read if you're interested in thinking through some of those implications. So those are some of the factors there that I just want you to think about. But hospice, back to the question where we were there, hospice is a very important issue, and that takes us back to the last paragraph on page 3 there. When you're talking with your doctor, don't be afraid to ask questions. What are the side effects of the drugs you're taking? Are those drugs actually, are those side effects worth it for the thing you're treating? Let me give you an example there. Is it important to treat cholesterol when you're 85 years old? Why? And yet you can't imagine how many people I see coming into the clinic who are on cholesterol drugs and getting side effects from them when they're 85 and 90. Why?
Tom, when my grandma was 83 years old, they were trying to tell her with me and stuff, and the doctors and everything, and I sat down there and said, okay, Grandma, I love you, but how many more years do you think you're really going to live?
Yeah.
And she didn't really know, so I said, I took a guess. And I said, so what does it really matter what you eat or not? And so she told the doctor to just jump in the lake.
Yeah. Okay.
I think that also pertains to mammograms.
Yeah, oh yeah, yeah. That's from the radiology text. Yeah, that's right. Yeah. How aggressive is it worth doing? How far should we go with this sort of thing? Yeah.
Just from my own experience, sometimes you go to the doctor and they say, you know, you're taking all these medications. Is there anything I can eliminate? I say that, or like my husband, and he won't say you can stop any of them.
Well,
Then the cholesterol, I don't see any point in that because of the side effects.
Yeah. That's a question that I can't say what you can do, but you know, this has to be a relationship between you and a provider you trust and all that. But those are serious questions because, and Peggy, you probably know the number better than I do, but as you increase the number of drugs, the side effects increase exponentially. Is it 10 drugs or something like that? We can guarantee there's going to be X% of side effects. I can't remember the exact numbers there.
I don't know.
But there have been very good studies on that. And how many people are on 10 drugs? Oh my, many. And when I say drugs, I'm not just talking about prescription drugs. I'm talking about all the over-the-counters. I'm talking about the nutritionals, the vitamins, all this stuff we put in. You start adding it up, you get into a lot of interactions of one with another and so forth. I really want to move on, and that's where we're in the medication thing there. Elderly take more drugs, all these extra things. Use generics whenever possible. That's very appropriate. When you're going to visit the doctor, bottom of page 4 there, be sure that you're taking a family member. The older you get, the more often you want to the older you get, the more seriously you want to think about having a family member along. So you got 4 ears, especially if those ears are starting to fail a little bit. You want those extra ears along and somebody to help ask questions, maybe write some stuff down. Always take a written list of your questions and concerns before you go. Don't just go in and expect to have the answers right away. Take a list, written. Yeah, right.
Is it appropriate to take a handheld recorder, have the doctor give a description in the recording, you can play it back?
I would say it'd be okay, but you wanna make sure
Yeah,
the
make sure,
doctor's aware.
that's a possibility,
Yeah.
because you can get these for $20, handheld recorder, you can everything
Those
recorded that
handheld
way.
recorders are real nice, and it's a good way, and then you can go over it again.
Right.
So, but you gotta get permission.
Yeah, sure.
Yeah. And, don't expect to have all your problems fixed up in 10 or 15 minutes of an appointment.
Why not?
You can't imagine how many people come in and they just think, I've got this, and this, and I wanna get it taken care of today. Whoa. You need to let the doc know, the doc appointment scheduler know ahead of time that you're gonna need an extra long appointment. Don't even try. I mean, deal with the 2 or 3 things that are the very most critical and get another appointment for the rest of them. That kind of thing. Don't be afraid of second opinions. Every insurance I've ever encountered is happy to have you get a second opinion. If somebody's talking about surgery, if somebody's talking about a major procedure of some sort, don't just go into it blindly. Get a second opinion from a different doctor in that specialty, in a different network or a different hospital, so that you're going to get a more unbiased or a different view of things. And then you can talk it over, make decision with family, and again, you've got somebody along with you, so you're getting that extra input. And don't be afraid to find out if the insurance is going to cover that procedure. You never want one of those surprises where you get the procedure and then find out, oops, that wasn't covered. So that's not good. The whole issue of hospitalizations, there's a lot more risks of being in the hospital. That's why we tend to kick people out real fast. The longer you're in the hospital, the more risk there is of complications, whether it's infections or bed sores or blood clots or you name it. Immobility of all sorts, it's really a problem. So we try to get people out very quickly. And some people grumble about that. Oh, I don't want to go yet. I came here for rest. Well, no. No, that's not why you're in the hospital. One of the big concerns that's going on right now currently throughout this country is the issue of hospital readmissions. The risk is, if we send people out too quick and didn't solve the problem, they're going to be right back in, and then our government says, we're not going to pay for that second rehospitalization, or we're going to penalize the hospital for getting you back in so quick. So the questions have to be answered, yet we want to get people out in a timely fashion, and that's a very delicate balancing act. Many hospitals now are doing what I would almost call an unethical thing, but it works, and that is what they call observation stay, where you go into the hospital, in the emergency room, they see you, and they say, we're not going to put you in the hospital, we're just going to put you in an observation bed. Well, when you go in the bed, it's going to look just like any other hospital room. It doesn't necessarily look any different, but they're classifying you as observation, and they keep up to 3 days that way in an observation setting. And then they send you out, and then if you wind up back in again 3 weeks later, they don't get penalized. So it's kind of a working, skirting around the law kind of thing, but it's what's being done in order to avoid that problem. So that's a real issue.
Dr. Tom?
Yeah.
I just read recently that they're working on firefighters coming to the homes of those who have just been discharged from hospitals as a way of following up with them to make sure they're taking their meds and they're
Firefighters and others. Hey, that's a great role for parish nurses, by the way, too. We've been talking about that here, too. The different kinds of people who can follow up in that way. Issues in the hospital, I'm not going to, you can read that, and next week we'll be talking about some of those important documents. I have listed on the last page there some of the issues with the process of death. A lot of people are really, really worried. Oh, I don't know, I've never done this before. I don't know what to expect. What's death gonna be like? Is it gonna be painful? Is it gonna be terrible? Is it gonna be a horrible experience? Is it gonna be a good experience? And wow, each person is unique on this. Here are some of the physical things, just the physical side now. Loss of appetite, loss of energy and increased weakness, increasing fatigue, increased time sleeping, social withdrawal. Sometimes with a little burst of energy, but then social withdrawal. Mental confusion and disorientation. Decreased body function, output, stool, urine, that sort of thing. Gradual swelling and cooling of the extremities. The circulation isn't as good anymore. Mottling of the skin, kind of darker colors in the dependent parts of the body. Difficulty breathing. Finally, cessation of breathing. And then absent from the body, present with the Lord. Now, all of this is a general picture. But the reality is it also varies with the individual and with the disease, with the particular thing that they're facing. And so issues of pain management and issues of oxygen deprivation are the two biggest, hardest issues to deal with. There are very, very good drug programs for handling pain and oxygen. They both relate in one way or another to morphine. Morphine is a really good drug, but it has to be done right. There is such a thing as greatly overdosing, and when the person is just unconscious and finally drifts away. There are ways of handling it, and quality people, people who know what they're doing, oncologists and palliative care people and geriatric staff and so forth, they are good at this, they're trained in this, and they can do it well, so you don't have to have a painful death. There'll be discomfort, but it doesn't have to be horrible pain if it's done right. And people who are running out of oxygen, they just can't breathe. Air hunger is one of the things that just drives. It becomes misery unless it's done right. And again, morphine is a really good one, done well. So I say all that because, yeah, you guys have to go ahead. I say that these are things that are very important to think about and be aware of. I'd be glad to answer questions or whatever as we close. I do want to end, if you want to look with me at Psalm 90. Psalm chapter 90. This is one of those favorite ones that many of us read and love and have known for years. And I just want to point out some things here. Moses is writing this. Moses said, Lord, you've been our dwelling place through all generations, before the mountains were born, brought forth the earth, the world, everlasting to everlasting, your God. 1,000 years in your sight are like a day that's just gone by. And then drop down a ways to verse 10. The length of our days is 70 years, or 80, if we have the strength. Yet their span is just but trouble and sorrow, for they quickly pass and we fly away. Remember that song from Fiddler on the Roof? Sunrise, sunset, how swiftly fly the days, you know. It's so true, you know. Verse 12, what's the lesson for us today? Teach us to number our days aright, that we may gain a heart of wisdom. Teach us to number our days, to think about how we can best use whatever days we have left to be most effective, to help others, to do things for our children, or grandchildren, or great-grandchildren, to do things that will really make our time remaining most effective, and that we may gain a heart of wisdom. Our priorities. What are we doing with our life? Bob, will you close us in prayer?
Yeah. Father God, thank you for this time together. Thank you for this opportunity to learn. And we just pray for the wisdom for each person in this room as we go forward in life. In Jesus' name.
Great.